Harrison Insight.
Welcome back to the deep dive. So today we are undertaking a really deep dive into the surprisingly complex world of heart failure, or HF. And based on the great source material you've shared with us, our mission is to unpack not just the textbook signs, but, the diverse and often surprising ways it shows up.
It's such an essential topic.
Yeah.
Because the thing is, heart failure symptoms are not uniform.
Right.
If you really boil it all down, most of the symptoms, they're rooted in one single issue: volume overload.
Okay.
This overload elevates venous pressures. But here's the key. The symptoms you actually see depend completely on where that pressure backs up.
So like a traffic jam.
Exactly. If it backs up into the lungs, you get left heart failure symptoms.
Yeah.
If it backs up into the rest of the body,
Yeah.
well, that's right heart failure.
That makes the categorization sound simple, but I know the symptom list isn't. Okay, let's unpack this, starting with the pulmonary system. Because shortness of breath, dyspnea, that's the absolute cardinal sign of left heart failure, right?
It is, exactly. And for you, the listener, it's important to understand this isn't just running out of breath. It's a whole spectrum.
A spectrum of severity.
Right. It starts as what we call exertional dyspnea, getting winded doing something that used to be easy.
Mm-hmm.
And in the worst cases, it progresses all the way to dyspnea at rest.
So what is actually mechanically happening inside the lungs to create that sensation?
It's really a cascading failure. When the left side of the heart can't pump effectively, blood backs up into the pulmonary veins. You get congestion.
Pulmonary venous congestion.
Yep. And that increased pressure forces fluid to literally leak, or transudate is the technical term, out into the lung tissue.
Into the interstitium and then the alveoli.
Precisely. Into the interstitium first, and then it floods the air sacs, the alveoli.
Which sounds like it would make the lungs feel stiff.
It does. That fluid makes the lungs physically less compliant. They become stiff, inelastic, and at the same time, it increases airway resistance.
So it's harder to breathe in and harder to breathe out.
Exactly. And that creates this whole cascade of gas exchange problems. You get hypoxemia and something called a ventilation-perfusion mismatch, a VQ mismatch.
Okay, VQ mismatch. Let's pause on that for a second. For anyone who's not a clinician, what's a simple way to think about that?
So think of your lungs like a factory.
Uh-huh.
The V is ventilation, the air coming in.
Got it.
And the Q is perfusion, the blood flowing past to pick up the oxygen. In a perfect world, the air supply and the blood flow match up perfectly.
Right.
But in heart failure, because of all that fluid, you have some areas that have blood flow, but the air sacs are waterlogged. They can't ventilate.
So the ratio's all wrong.
It's mismatched. The blood just rushes past without getting fully oxygenated, and that directly contributes to that feeling of breathlessness.
And the sources also point out this isn't just a mechanical feeling. There are nerves involved, these J receptors. How do they fit in?
Oh, they are fascinating. They're these juxtacapillary J receptors right near the capillaries in the lungs. When they sense that swelling and pressure from the fluid, they just start firing signals to the brain.
And what do those signals say?
They scream, breathe harder, breathe faster.
Mm-hmm.
So your body, which is already struggling with stiff, waterlogged lungs, is now getting this intense neurological command to hyperventilate. It's exhausting. It creates panic.
That's a fantastic detail. And I assume if the person keeps pushing, that low cardiac output means the breathing muscles themselves aren't getting enough blood.
You've got it. Those muscles, they start working anaerobically, they produce lactic acid, and that just adds another layer to the sensation of severe dyspnea and fatigue. It's a really vicious cycle.
Now let's talk about how position changes things. This is where we get into orthopnea versus paroxysmal nocturnal dyspnea. So orthopnea is when you get breathless almost immediately after lying down.
Yeah, it's basically a hydraulics problem. When you go from sitting up to lying flat, gravity's effect on your lower body changes.
So all the fluid that was pooling in your legs?
Right, in your legs and abdomen, it all redistributes. It just rushes back into your central circulation right into your chest.
And within a minute or two of lying down, that fluid surge just overloads the already struggling lungs.
Exactly. It's an immediate, predictable problem. And the sources are clear that it's also quickly relieved. The patient just has to sit up, prop their head on some pillows.
And they feel better almost instantly.
Within a minute, often. They learn very quickly to sleep propped up, sometimes almost sitting in a chair. And you'll often see a nocturnal cough with it too.
Okay, so if orthopnea is that quick and predictable, what makes paroxysmal nocturnal dyspnea, PND, so different?
Well, PND is much less predictable and honestly a lot more frightening for the patient.
It doesn't happen right away.
No. It wakes them up suddenly from a deep sleep, usually a couple hours after they've gone to bed.
Why the delay? What's happening over those 2 hours?
The thinking is that it's a more delayed process, maybe a slow equalization of pressures, and it can be made worse by things like central sleep apnea.
Mm.
But the key thing is the severity. The patient has to bolt upright. They might run to an open window gasping for air.
And the relief isn't quick.
Not at all. It can take 30 minutes or even longer to feel better.
And PND is often linked to that term, cardiac asthma. Is it actually asthma?
That's a really important distinction. It's not. It presents with coughing and wheezing, so it looks like asthma.
But the cause is different.
The cause is totally different. It's about pressure. The high pulmonary pressures cause the bronchial arteries to swell, which then compresses the airways. It's a mechanical squeeze, not an allergic inflammation.
And then the most severe state, acute pulmonary edema, that's the emergency room pink frothy sputum situation.
Yeah, that's the end stage of this process.
Yeah.
That pink frothy sputum is literally red blood cells and fluid being forced out of the capillaries and into the air sacs. It's an uncontrolled flood in the lungs. It needs immediate help.
Before we move on from the lungs, there's a really important clinical insight for you, the learner, to keep in mind. We use the New York Heart Association, the NYHA classification all the time.
Right, class I through 4V, based on how much effort it takes to make you breathless.
But the sources stress something important here.
They do, and it's that this functional classification, which is just based on what the patient tells you, it often does not correlate well with the objective numbers.
Like ejection fraction or ventricle size.
Exactly. It doesn't track well with ejection fraction, LV size, or even peak oxygen consumption. It's a useful way to track symptoms, but it's a subjective snapshot, not an objective measure of the heart's function.
Okay, that's a great point. Let's flip the system now. We've done the lungs, left HF. Now we get to right heart failure, and this is where it gets really interesting because it's all about that systemic backup into the body.
Yeah, and the symptoms here become much more, well, insidious and widespread.
What are the first signs?
The very first signs are usually just simple fluid retention. Some weight gain, some swelling in the lower legs and ankles, pitting edema.
But the real aha moment, the thing people don't expect, is the GI symptoms.
This is it. This is the classic clinical trap.
We're talking about bloating, stomach pain, not feeling hungry.
Yeah.
Why is the gut getting involved in heart failure?
It's all about that backup pressure again. The systemic congestion causes the wall of the bowel itself to get edematous, to swell up.
Which would slow everything down.
Slows motility, causes malabsorption, but even more important is what happens to the liver, hepatic congestion.
And what does that feel like for the patient?
It's a whole constellation of misery. Abdominal bloating, really severe anorexia, early satiety so they feel full after just a couple bites of food.
And pain.
Yes, often a nagging right upper quadrant pain. That's from the liver swelling and stretching its capsule. And that can come with nausea and vomiting too.
Wow, that just sounds like a recipe for misdiagnosis.
It's a massive setup. You have a patient with abdominal pain and nausea, and you run labs, and their liver function tests are abnormal because of the congestion. So you naturally and wrongly start thinking about gallbladder disease or hepatitis. You completely miss the heart.
It's a huge clinical pitfall. And when right HF gets really, really bad, we get to the most severe sign, anasarca.
Anasarca. It's a powerful word for a devastating condition. It's massive generalized edema. The entire body is swollen.
So not just the legs.
Not just the legs, it's the entire body. Often with recurrent pleural effusions, fluid around the lungs and ascites, which is fluid in the abdomen. It means the system is completely overwhelmed.
Okay, so we've covered congestion in the lungs and the body.
Right, but now we have to shift gears completely and look at the other side of the coin, reduced cardiac output, the low output syndrome.
And this is where we get into the really non-specific but just debilitating symptoms. And the biggest one is just fatigue, pervasive weakness.
It is. It's non-specific, but it's profound. And this fatigue, it's coming from a couple of different failures. First, obviously, there's just less blood flow getting to your exercising muscles.
That makes sense.
But second, the body is trying to compensate. It's pumping out neurohormones like adrenaline.
Trying to keep the blood pressure up.
Trying to keep the blood pressure up. But the net effect of that is that it clamps down on blood vessels everywhere. You get this increased systemic vascular resistance.
So even though the pressure is maintained, you're starving the muscles of oxygen.
You're starving them.
Yeah.
It leads to this massive intolerance for any kind of exertion.
And the sources say this isn't just a temporary flow problem, it actually changes the muscles over time.
That's a really fascinating piece of the pathophysiology. Over time, that chronic low flow state, it actually triggers changes in the skeletal muscle itself. The structure, the metabolism, it all changes.
So the muscles become less efficient.
They become less efficient. It contributes to what we call a cachectic state in severe HF. It means even if you could magically restore blood flow, the muscles are no longer equipped to use the oxygen properly.
So fatigue isn't just the heart being tired, it's the whole body remodeling itself for survival. And you have to connect this to the brain too.
Absolutely.
Yeah.
Especially in older patients who might already have some cerebrovascular disease.
Okay.
That drop in perfusion is enough to cause real cognitive symptoms. Mental dullness, confusion, a depressed affect. The brain is literally being underfueled.
We should add a caveat here, though. Fatigue it's the great masquerader.
It is. A clinician always has to rule out other causes. Is the patient volume depleted because of too many diuretics? Do they have an electrolyte imbalance like hyponatremia or anemia, especially iron deficiency?
Or even just a side effect from their beta blocker.
Exactly. All those things have to be considered.
Let's pivot one last time to sleep and urination. Poor sleep makes sense, especially with all the nocturnal dyspnea we talked about.
Yeah.
But the urinary symptom is really counterintuitive. Nocturia, waking up all night to urinate. Why would someone with a weak heart suddenly start making tons of urine at night?
It's a beautiful mechanical quirk of redistribution. During the day, when you're upright, fluid pools in your legs, and with poor cardiac output, your kidneys are underperfused. They're sort of hibernating.
Okay.
But then you lie down. Venous return to the heart dramatically improves.
All that fluid rushes back.
Exactly. That boosts cardiac output for a little while, and suddenly the kidneys get this massive surge of blood flow they were missing all day.
And they kick into high gear.
They kick into high gear and start producing a ton of urine. Plus, any diuretic they took earlier might have a delayed effect. The result is they're up 3, 4, 5 times a night.
The body is literally catching up on its kidney function while they're trying to sleep. That makes perfect sense. And the opposite end of that is oliguria.
Right. Significantly reduced urine output. And that is a very bad sign. It means the cardiac output is so low that even when lying down, the kidneys aren't getting perfused. It's a red flag for advanced, unsayable disease.
Okay. So let's bring this all together and talk about that crisis moment. We know patients can be stable, even asymptomatic, for a long time because the body is compensating.
But that stability is fragile. It is incredibly fragile. The sudden shift from being stable to being acutely ill is called decompensation.
And it's almost always triggered by something.
Almost always. It happens when one or more factors pile on and increase the heart's workload, disrupting that very delicate balance.
And the sources had a pretty staggering statistic on this.
They did. That in 50 to 90% of hospital admissions for acute heart failure, you can identify a specific precipitating factor.
Wow.
Which tells you that it's often not the heart itself that just suddenly got worse. It's that something else pushed the system over the edge.
And these factors can be anything, right? A patient not taking their meds, eating too much salt.
Or a provider making a mistake with their diuretic dose. Or an underlying issue like anemia flaring up. Or just getting a simple infection like pneumonia. Thank you for sharing the sources that let us put this whole clinical picture together.